Welcome to the Explainer. Today, we're skipping all the background fluff and jumping straight into a massive new meta-analysis published in Nature Medicine that completely changes how we understand blood pressure medication. For a really long time, the way we thought about preventing cardiovascular disease relied on a few core assumptions. But as we're about to see, one of the biggest assumptions we've made about hypertension treatments might actually be completely wrong. So, here is the big question at the heart of all this research. Do the benefits of blood pressure meds actually compound over time? For years, the medical community kind of just assumed that blood pressure medications acted like cholesterol medications. With cholesterol drugs like statins, the relative benefits get exponentially better the longer you take them. They have this compounding legacy effect. So naturally, the thought was, hey, if you start blood pressure meds early and stay on them forever, your proportional risk reduction will just keep multiplying year after year, right? Well, to answer this definitively, researchers didn't just run some tiny localized study. Nope, they pulled together individual participant-level data for a staggering 358,642 people. That is an incredible scale of data. It gives us the statistical power to finally track exactly how these treatments behave over long stretches of time without having to rely on proxies or educated guesses. Okay, let's look at what's actually inside this incredible dataset. The researchers combined 51 randomized trials from the Blood Pressure Lowering Treatment Trialists collaboration. We're talking about a median follow-up time of 4.2 years here. And what they were specifically tracking was MACE, major adverse cardiovascular events. Basically, fatal or non-fatal strokes, ischemic heart disease, and heart failure. They wanted to see exactly when these events were happening and just how effectively the medication was preventing them year by year. That brings us to Section 1. Early benefits, no compounding. Right out of the gate, the researchers found something incredibly surprising. Just in the very first year of treatment, a simple 5 millimeter of mercury drop in systolic blood pressure resulted in a rapid, highly effective 12% relative risk reduction for major cardiovascular events. That is a massive benefit, and it establishes itself within months of starting the therapy. It's a real testament to how quickly taking that mechanical arterial stress off your heart and brain actually works. But here is where it gets really interesting. You'd think that protective effect would just keep diving down exponentially over the years, right? Well, it doesn't. The protection emerges incredibly early, but then it just completely flatlines. The relative risk reduction just plateaus. It absolutely does not progressively amplify the longer you're on the treatment. If we break down the raw numbers from the study, it becomes crystal clear. That initial 12% benefit, which is represented as a hazard ratio of 0.88 in year 1, actually attenuates just a tiny bit over time. In subsequent years, the hazard ratio hovers right in the 0.90s, eventually landing at 0.94 at the greater than 5-year mark. So the relative protection locks in fast, but it literally refuses to compound. And this is a huge deal because it shatters previous assumptions and highlights a massive difference in how our most common preventative drugs work. Unlike cholesterol medications that aggressively compound their relative benefits year over year, starting around a 14% reduction in year 1 and snowballing to 20 to 30% in each subsequent year as they actively reverse plaque, blood pressure treatments simply don't act like a compounding investment. Let's move on to Section 2, the absolute risk reduction. So if the relative benefits plateau, does that mean taking the medication for years is pointless? Definitely not. This is a statistical paradox waiting to be resolved. The pivot here is understanding the vital difference between relative risk flatlining and absolute risk. Relative risk is just the percentage of risk reduced compared to a control group. That's the part that plateaus. But absolute risk, the actual tangible number of real-world heart attacks and strokes prevented, tells a much more encouraging story. Because you are continually exposed to the medication day in and day out, the absolute risk reduction for major cardiovascular events keeps climbing steadily. It starts at a 0.30% cumulative absolute risk reduction in year 1. But as your continued exposure allows the benefit to pile up, that number climbs steadily to 1.25% by year 5. So the percentage of protection isn't increasing, but the sheer volume of events you're preventing is constantly growing. To put that into perspective, let's talk about the number needed to treat, or NNT. In year 1, a doctor would need to treat 337 people to prevent just one major adverse cardiovascular event. But by year 5, because that absolute benefit has been steadily piling up, that number plunges down to just 80. You only need to treat 80 people to prevent a major event by year 5, proving that absolute benefits are massively accumulating over time.
Which brings us to Section 3, the clinical bottom line.
So, how does resolving this paradox change how doctors and patients should actually approach preventative blood pressure care today? Well, the data gives us a super clear roadmap. First, it confirms that across almost all major classes of blood pressure drugs, ACE inhibitors, ARBs, calcium channel blockers, and diuretics, the protection locks in early, usually within months. Second, those relative percentage benefits do not progressively amplify. But third, and most importantly, the absolute benefits continue to accrue with ongoing exposure. Here's the real kicker, and exactly what the researchers concluded. We cannot put low-risk people on these medications with the false assumption that decades of treatment will exponentially compound into a massive relative benefit. Because the relative benefit plateaus so early, clinical decisions really should be driven by a patient's actual baseline cardiovascular risk today, targeting those who need the absolute risk reduction the absolute most. To wrap up this explainer, we are left with a pretty critical question for our own health journeys and for the broader medical community. Are we optimizing our treatments for the actual risk we face today? Or have we been chasing a false expectation of a compounding miracle tomorrow? Understanding how our medications truly work over time is the very first step in making the right choices for our long-term health. Thanks so much for joining me, and keep asking the right questions.